So now moving on to the next topic, the combination vaccines. We'll have an introduction by Dr. Moore.
As Dr. Moore is getting ready, I do want to clarify something about this combination vaccine section because I know that there's a lot of, this is a big day with a lot of votes. So for combination vaccines, as you'll hear, we do not have to vote for ACIP, but we will have VFC votes. Therefore, for this session, we will not need to put any motions on the table during this session. We can put the VFC motions on the table during the voting session after.
My name is Kelly Moore. I'm welcoming you to the ACIP Combination Vaccine Workgroup session. And as we call up the slides, I want to thank my colleagues who are on the workgroup, especially our consumer representative, Veronica McNally, who joins me as the other voting member on this, and want to acknowledge all of the hard work of Sarah Oliver and her team. And those are the work group members and liaison representatives. Also, the CDC contributors were especially important because with the combination vaccine, we needed subject matter expertise on every component of the vaccine, and that required collaboration from across the agency, and we appreciate everyone's input. So what are we talking about today? The pediatric hexavalent vaccine. This vaccine, to remind everyone, is a joint venture between Merck and Sanofi Pasteur that combines DTaP5, IPV or polio, Hib vaccine, and hepatitis B vaccine. Its official abbreviation is listed. The dashes in between indicate that each component is liquid. And I learned this as a part of this process. When there's a slash, that means that one is a powder and has to be reconstituted, but dashes mean all parts are liquid. This is given in a 3-dose series at 2, 4, and 6 months of age, and it was approved and licensed by the FDA back at the end of December. But it is important to note that although we're discussing it today, and we will have a VFC vote on this today, potentially, the manufacturer has stated that the vaccine will not be commercially available in the U.S. prior to 2021 in order to assure adequate supply to meet demand. So the topics under consideration initially for our work group was first to consider if this new vaccine should be preferentially recommended for the American Indian, Alaskan Native population, and second, to consider whether it should be added to the VFC program as an option for the infant series at 2, 4, and 6 months of age. Now, the preferential recommendation would have required an ACIP policy vote. We discussed in February some of the reasons that the work group had not advised moving forward on that, and Sarah Oliver will discuss that in her presentation. So the recommendation to add this to the VFC program requires only a VFC vote, and she'll describe that today. Since we have met the ACIP work group back in February, discussed several different topics, including the immunogenicity and safety of this vaccine, epidemiology of Hib disease, and vaccines in the American Indian and Alaskan Native population. The special considerations there was presented by Laura Hammett, and then Sarah Oliver gave an update at that time of our work group considerations at that point. Since then, we've had a number of work group calls reviewing again immunogenicity and epidemiology, as well as the use of combination vaccines in infant series, and discussed our policy options. Later this year, we will publish the MMWR policy note related to this new licensed vaccine. So our agenda today is very brief. Sarah Oliver will present a summary of our discussions and a brief presentation of relevant components of the evidence to recommendations framework for this vaccine, and then we'll have VFC votes. And I know Jeannie Santoli is not here, and so we will have Frank coming and speaking on her behalf to lead us in the VFC votes. All right. Thank you very much, and I'll turn it over to Sarah Oliver.
Thank you, Dr. Oliver.
All right, good afternoon. So first, I will briefly review the topics under consideration, and then present the relevant aspects of the evidence to recommendation framework and the workgroup interpretation. As a reminder, here are the two policy topics under consideration. First, to consider if the new pediatric hexavalent vaccine should be preferentially recommended for the American Indian and Alaska Native, or AIAN, population. And next, to consider if the pediatric hexavalent vaccine should be included as an option in the Vaccines for Children program for the infant series at 2, 4, and 6 months of age. First, I'll provide a brief summary of the information presented at the February ACIP meeting and discussions on this first topic. In the pre-vaccine era, Hib disease occurred at a younger age among the AIAN population compared to the general U.S. population. This graphic is from Dr. Hammett's February presentation, showing the peak of Hib meningitis at 4 to 5 months of age among Native American children, compared to 6 to 9 months in the general U.S. population. In addition, PRP-OMP vaccines can achieve protective immunity in a majority of infants after the first dose. Dr. Hammett also showed this table, highlighting the ability of PRP-OMP vaccines to achieve protective immunity in 91% of infants after the first dose, much higher than what was seen with other Hib vaccines. It is because of these factors to provide necessary protection early in infancy that PRP-OMP vaccines are preferentially recommended for the AIAN population. That preferential recommendation was based on immunogenicity data after the first dose. The available data for the second and third dose of the new hexavalent vaccine shows a robust response. However, there's no data post-dose 1, which would provide an important information for that window of vulnerability seen in this population. So because of this, the workgroup and ACIP members felt that immunogenicity data post-dose 1 is needed before ACIP could consider a preferential recommendation for the AIAN population. So because of that, we will only be presenting the relevant evidence to recommendations framework on this second topic to consider if the new pediatric hexavalent vaccine should be included as an option in the VFC program. At this time, there is no proposed ACIP vote that would change current ACIP policy, only adding an additional vaccine option to the VFC program. Because of this, the full evidence to recommendation framework was not undertaken. However, to present evidence in a standard and transparent format, there are aspects of the evidence to recommendation framework that are relevant for this new combination vaccine: benefits and harms, values, acceptability, and feasibility. I'll present available evidence on these aspects. First, for the potential benefits and harms. I'll first discuss potential benefits of this specific vaccine. Given that all components of the pediatric hexavalent vaccine are currently licensed and recommended, the immunogenicity studies conducted were non-inferiority studies comparing each antigen in the new vaccine to currently licensed vaccines. Overall, non-inferiority criteria were met with 2 exceptions. First, non-inferiority was not met for the geometric mean concentrations for one of the 5 pertussis antigens, FHA, at the post-dose 3 time point. However, it was achieved with the percent that met a pre-specified vaccine response. Next, one of the 13 pneumococcal antigens, 6B, missed the pre-specified non-inferiority endpoint post-dose 3. However, it would have met the non-inferiority endpoints used in the PCV13 studies. As was mentioned in February, antigen or serotype-specific correlates of protection are unknown, so it's unclear whether these differences would be clinically relevant. However, there are 5 pertussis antigens included in the vaccine, and only one antigen at one time point did not meet preset non-inferiority criteria. In addition, the non-inferiority criteria were met for all other PCV13 antigens, and serotype 6B rarely causes invasive pneumococcal disease among U.S. children in the post-PCV13 era. Next, I can discuss the benefits of combination vaccines in general. combination vaccines merge equivalent component vaccines into a single product to prevent more than one disease. An increased number of vaccine doses due is associated with deferring doses, leading to missed opportunities and decreased coverage. However, the receipt of at least one combination vaccine has been found to be associated with improved coverage rates, both among individual vaccines as well as for completion of the full infant vaccine series. Next, to potential harms of the new hexavalent vaccine. Overall, the vaccine has a safety profile consistent with the licensed component vaccines. There was a higher rate of fever, particularly when compared to the pentavalent regimens. However, there was no increase in fever-related medical events, such as hospital visits or febrile seizures. And next, to potential harms of combination vaccines in general. As stated in ACIP's General Best Practice Guidelines for Immunization, potential disadvantage of combination vaccines include adverse events that might occur more frequently after administration of a combination vaccine compared with administration of separate antigens, confusion or uncertainty about selection of vaccine combinations and schedules for subsequent doses, especially when vaccinations are given by multiple providers who could be using different products. Reduced pathogen coverage if the combination product covers fewer of one particular vaccine-preventable disease-causing agent. Extra doses of certain antigens could be given in combination product, and there could be a shorter shelf life than individual component vaccines. It's worth noting that not all of these potential disadvantages would apply to this specific vaccine. Now I'll discuss values and preferences. There's no specific data about the new hexavalent vaccine and values of the target population. However, ACIP and the American Academy of Pediatrics have statements regarding the value of combination vaccines. The ACIP General Best Practice Guidelines for Immunization state that the use of combination vaccines can reduce the number of injections patients receive and alleviate concern associated with the number of injections. The use of a combination vaccine generally is preferred over separate injections of equivalent component vaccines. Considerations should include provider assessment, patient preference, and the potential for adverse events. In addition, the 2018 Red Book states that combination vaccines represent one solution to the issue of increased numbers of injections during single clinic visits and generally are preferred over separate injections of equivalent component vaccines. Now to acceptability. There have been no specific studies regarding this new hexavalent vaccine and acceptability among stakeholders. However, there have been evaluations for acceptability of combination vaccines overall. A prior evaluation of combination vaccines in 2003 among Medicaid patients in Georgia showed that 85% of children received at least one combination vaccine in the first year of life. For a more recent assessment, we evaluated the frequency of combination vaccine and single vaccines for the infant series in multiple birth cohorts from 2014 to 2018. We used data from the Immunization Information Systems, or IIS, and this evaluation assessed two different antigens, DTaP and Hib. The evaluation was conducted at 6 IIS Sentinel sites. The IIS systems have provider-submitted, population-based data that is timely and covers all pediatric ages. However, given that it's only 6 sites, the information may not always be generalizable. This figure shows DTaP administration frequency by vaccine type and birth cohort. There are 2 pentavalent combination vaccines that contain DTaP, and as shown here in gray, over 90% of DTaP doses over this time frame were given in a combination vaccine. When assessed for a different antigen, Hib, which is only included in one pentavalent vaccine, 40 to 60% of Hib doses were given in a combination vaccine. Next to feasibility. The additional combination vaccine will not alter the established vaccination schedule. As the vaccine is only licensed for the primary series at 2, 4, and 6 months of age and not for booster doses, there will need to be additional considerations for having additional product or products available for booster doses. And as mentioned already, the new vaccine will not be commercially available prior to 2021. So for the summary, the workgroup reviewed relevant evidence to consider if the new pediatric hexavalent vaccine should be included as an option in the VFC program for the infant series at 2, 4, and 6 months of age. The balance of benefits and harms would support making the vaccine an available option. The target population appears to value combination vaccines in general, as well as seems acceptable to key stakeholders. Therefore, the overall interpretation of the evidence is that the workgroup is supportive of including this vaccine in the VFC program as one of the available options, and the workgroup was in agreement on this. Next, at the designated time, there will be 4 separate VFC resolutions for each of the 4 separate vaccine components, and we'll motion for a VFC vote after each individual VFC presentation. Thanks, and I'm happy to take any questions.
Thank you very much. A discussion, Dr. Atmar.
So if this is added to VFC and for the AIAN population, there will still be a preferential recommendation for Hib-OMP?
It will be for Hib-OMP, but for not this vaccine. So for the other, there's only one other Hib vaccine. So it'll remain for the other PRP-OMP vaccine, the single antigen PRP-OMP vaccine, unless post-dose 1 data is available to review.
So the consequence would be that in that population, because there's a preferential for the Hib-OMP, they would get the Hib-OMP plus a pentavalent. Is that?
That's one of the options that they could. Essentially, there will be no change in the vaccine schedule for the AIN population at this point. And that could change if there's post-dose 1 data that's available at a different time point.
Any other questions or comments from the work group? None. Any from Kelly? Dr. Moore?
I think our work group is very hopeful that we may have post-dose 1 data that, because that shouldn't be a long drawn-out type of study, that it could be available and potentially even considered by future ACIP members around the time that the vaccine were to come onto the marketplace. But for right now, we would leave the AIAN population recommendations unchanged, but hopefully that information will be available in the not-too-distant future.
ACN.
Carol Hayes with the American College of Nurse Midwives. I had a question about the birth dose for Hep B. So how would this combo vaccine impact the birth dose?
So the birth dose is still recommended, and this would just be given at the 2. It's not licensed for the birth dose, so it would be given at 2, 4, and 6 months.
So then the children would be getting 4 Hep B vaccines?
Yes, there would be an extra Hep B dose if this vaccine was received at 2, 4, and 6 months.
Dr. Hunter.
I have a question for AIM representative and maybe other people who do this. Given that the vaccine is not going to become available into 2021, I am assuming that us voting now is going to help you get prepared for when it does come, and it would be helpful to get it voted on now rather than waiting. Is that correct?
Yes, that would be correct, and also it would allow time to think about educational information that we would provide.
Anyone else? Okay.
I just want to remind everyone, because this is not a policy change, there are no changes being proposed to the current recommendations. It's just another option for use. We will make a motion for the VFC resolutions after the public comment period and after the other 2 votes, and then vote on each resolution separately at that time.
Okay, would everyone please take their seats? We're going to begin the public comment session for today. There'll be another session tomorrow. So Let me begin by saying, from the onset, I'd like to welcome and thank all public comment speakers for addressing the committee today. Your comments are very important to us, and we take them into consideration. All speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined by a lottery. For the speakers, I ask you to please, we have a limited amount of public comment time, and in order to make it through all of the list of speakers, it's extremely important that each speaker limits his or her remarks to the 3 minutes that they are allotted. We will be displaying the time on the screen that you'll see behind me so that you know how much time is left. Public input and engagement is vital to the ACIP's work. We appreciate your presence here, and we look forward to the comments. Now, I'd like to say that at the end of your 3 minutes, I will say thank you for your comment. Your time has expired. If you extend another 30 seconds, at 3:30, I will make the comment. As a courtesy to other speakers, we ask that you conclude your comment, and then I don't think it will be necessary, but at 4 minutes, I will mention your comment time has ended. Thank you, and your mic will be cut at that time. So let's begin. Ms. Lynette Barron, please.
Hey, ACIP, it's good to be back. I've been coming here for several years now, trying to bring your post-market data to you and show you what the results of these vaccines are actually doing to us, to our families. It's very sad that we have to keep coming. It's very sad that this is even a topic, really, because, well, goodness, you'd think that we could all get along and we could talk about these things, and you would look at the science other than the science that's being bought. I have actually seen something today that I was kind of floored by, which was you guys actually conversating about something, talking it through, and that kind of blew my mind. I'm not sure if it's because there's way more press in the room today or if you're actually being genuine and with your concerns, but it was nice to at least see you guys talking things out today, so that's a welcome change. I'm sad to see the velvet rope that got put up last time and kind of blocking the interaction between y'all and us, because we're all human beings at the end of the day, and we all want what's best for our kids and our families. So that to me was a sad addition to this room. We don't come here to cause problems. We don't come here to cause disarray. We come here because we want you to understand what your post-market data really does look like. And it is these people back here. It is our children. It is our families that have been affected. And when we go home, we don't get to take a break from this. Like, you leave this room, this is, we have to go home and our crying children who are smearing poop and who can't talk and who can't do half of the things or more that they should be doing because of the vaccines. And it's mind-blowing to think that y'all aren't looking at those things. Y'all literally talk about the safety and efficacy, and so many times everything is assumed, everything is probably, it's uncertain. Every death that is talked about is written off and pushed under the rug as it wasn't related. At some point, you must realize that you can't keep sweeping it under the rug, and you actually have to look at the causes. I mean, your studies literally show you half these things, and you just make it statistically non-important. It doesn't make sense. I really do hope that as I will keep coming back. As I told y'all last June, I will be here on the front line like I have been, and I really do hope to keep seeing improvements, and I hope this goes away. But I do enjoy talking to y'all. I enjoy getting to know you and y'all getting to know us. I mean, like I said, we're all humans at the end of the day. Treat each other with respect. We don't come here to disrespect you or the process of this. We come here because we really do want you to understand where we're coming from as parents. I'm sure many of you are parents. We want the best for your kids too. I know I do. I don't know, what at the end of the day, what your goals are, what your motivations are. But if you're not listening to the people that are receiving these vaccines and telling you something is wrong, something bad has happened here, then I don't understand where you're looking, because we are your post-market data. And honestly, my family's done being your post-market data, and I'm pretty sure most of my friends feel the same way here. I really do hope, though, that we watch the science improve and actually see real science come into this room. There are a lot of people who aren't being paid by big pharmaceutical companies to do a lot of studies, and you guys should be looking at those because they show a lot different than what's being presented.
Your time has expired.
Thank you.
Thank you. Our next speaker is Kip Adams.
My name is Kip Adams. I'm here on behalf of the COPD Foundation, which represents more than 16 million Americans that are diagnosed with chronic obstructive pulmonary disease. Pfizer is one of our 21 corporate partners. They were not involved in the preparation of this statement, and I've received no support for my travel expenses. The COPD Foundation's mission is to prevent and cure COPD, improve the lives of patients and their caregivers affected by the disease. My purpose today is to express our strong opposition to any changes in the current PCV 13 recommendation for adults age 65 and older. COPD patients have a 6 to 8 times greater risk for community-acquired pneumonia, or CAP. When a COPD patient gets CAP, they have increased risk for developing exacerbations in the future. We conducted a study of people with COPD who have been diagnosed with CAP within the last 4 months. The average age was 50. They reported that CAP kept them from their work and usual activities for periods up to 2 to 6 or even more weeks. In addition, over 84% reported requiring assistance from family and friends for an average of over 4 weeks. We also found that CAP symptoms like cough and weakness limited people's COPD ability to go outside their home and interact with others. Given the challenges COPD patients face in obtaining comprehensive care, with existing vaccination rates already unacceptably low, changing the pneumococcal recommendations would be devastating to COPD patients' health and quality of life, and against the goals of Healthy People 2020 and the recently passed House Appropriation Bill, which calls for greater focus on improving pneumococcal vaccination rates. There's not been enough time or focus on increasing pneumococcal vaccination rates to ensure adults, especially those at greater risk, can benefit from PCV 13. A change would result in access issues and physician confusion that would cause lower percentages of COPD patients benefiting from the protection that both vaccinations offer, especially given that the current recommendations for immunocompromised patients do not include COPD patients. Further, simply downgrading the recommendation to be based on a physician's judgment is not a viable option, especially for our complex population. There's a high likelihood that delays in any pneumococcal vaccination will occur as a result of the confusion over the change and the fact that many are immunized at a pharmacy, and since PCV 13 is recommended to be first. Finally, I wish to provide you feedback, several quotes from our community of patients. We have a social network. One quote, getting over a month of home health care and hospitalizations for pneumonia and COPD flare and new heart issues now. I'm not the same person I was a month ago. Another quote, the hardest thing I've learned from having pneumonia
Your time has expired.
is taking so long to get back feeling like yourself again. It was a much slower process than I thought. Thank you.
Thank you very much. Our next speaker is Ms. Janelle Sullivan.
Hi, I'm Janelle Sullivan, founder of Heartline Foundation, and I have a vaccine-injured child. My son was severely injured from his MMR shot, and he was even more severely injured from the DTaP and the flu shot. He had a seizure afterwards, and I was told that that was completely normal. It would have happened anyway because he had autism. Well, my son no longer has autism. I detoxed his vaccines homeopathically, re-experienced all of the adverse reactions that he had. Puking out the nose, head banging, biting, poop art, and guess what? Today he is neurotypical. I recovered him the exact same way that Jennifer McCarthy did. And when I looked at these papers, and it says, for parents with concerns about vaccines and autism, you guys want them to read Autism's False Prophets, Bad Science, Risky Medicine, and A Search for a Cure by Paul Offit. That's how I recovered my child. Everything that he campaigns against. The homeopathic remedy, belladonna, got my son to stop biting himself to bleed instantly. He goes on news and says that it causes irreversible neurological damage, seizures, and death. My pediatrician repeated that to me. That caused my child. Well, it didn't cost him anything because I still gave it to him, and he's still on it. And when I ran out of it or misplaced it, I got a note home from the IU. He was back to biting his hands. Next, I was told that gluten was a load of garbage and that it wouldn't hurt him, caused my son to bang his head on cement to bleed and lose all speech. Without it, he could at least repeat words, and his self-harming went down dramatically. That's important. Next, she told me that I could safely give my child 3 vaccines at a time after a seizure. On top of that, after his reactions from 2 months, I thought he was going to die. So, pediatrician downplays that. It's crazy. So, I wanted 1 vaccine at a time. On 4 occasions, they gave my child 2 to 5 vaccines. Informed disconsent. It is written in my son's medical file that I want 1 vaccine at a time, but they gave him chickenpox and hepatitis A. Now, when my son was born, I was told, do you want to vaccinate him for a sexually transmitted disease that he can't possibly catch? And I said, no, I don't want to do that. So when he was 2 months old, I told the pediatrician, don't give him any unnecessary vaccine. She said, Hep A is not necessary. That was to trick me into giving him Hep B and everything on the schedule. That was not honest. Then when he got the chickenpox vaccine, he got hepatitis A also. Not honest. Our kids matter. They absolutely matter. Jennifer McCarthy did not start the anti-vaccine movement. She started the autism recovery movement. And the idea that you guys want to make autism, neurodiversity, something celebrated, no. It should be celebrated that my kid's playing soccer, that my kid's playing t-ball, that my son is no longer on the government's dollar.
Thank you for your comment. Your time has expired. Our next speaker is Ms. Alexandra Ponsica.
Thank you for letting me speak today in front of your committee. Both my husband and I are actually in the public health field. I'm also a mother to twin 7-year-old boys with severe autism, whom we know to be vaccine injured. From one public health person to another, I come to you with a heavy heart and feel burdened that you are dismissing the largest public health threat we have ever faced. In public health, we have been taught about the corruption in health history and unethical health research practices, Nuremberg trials, Tuskegee study, the tobacco industry, etc. In these times, we are not exempt from this occurring again, for it is in fact occurring again. I'm tired, I'm sad, I'm angry, I'm broken because of my boys' suffering. We wake up every day trying to give them the best life that we can. They cannot perform the simplest of activities of daily living without our full support. They are still in diapers, and they poop smear their faces and walls countless times a day. They headbang against the walls when they are frustrated or cannot communicate. Going out in public is near impossible, and if we try, it is exhausting. We are heartbroken over watching them struggle. One study showed parents of children with autism have the same cortisol levels as Holocaust survivors. The average lifespan of an individual with autism is 36 years. If the rate of autism continues to accelerate at current rates, by 2032, 1 in 2 children, 1 in 2 will be on the spectrum. If every child on the spectrum is as severe as my boys, I guarantee you our way of life as a society will be unsustainable. By dismissing this issue, you are creating greater issues and larger health disparities amongst a group of vulnerable individuals. Your recommendations are being used to take away an individual's innate human right to bodily autonomy without discrimination or coercion. Your recommendations are meant to do no harm, yet harm they do. The claim that vaccines don't cause autism does not have the science to back it up. You have not done a true vaccinated versus unvaccinated study, and the Denmark study does not qualify as it deceptively claims that vaccinated subjects were unvaccinated. It is troubling that you are about to vote on a combination vaccine which had 36 or 35 deaths in the trials due to SIDS. We do not know what the ingredients in vaccines do once they enter the body. We do not know how they react synergistically within the body, whether they lay dormant or exit the body, whether they enter the brain or how they affect the brain, and on the questions go. My boys' lives were stripped away from them. I beg you to call a moratorium on further vaccination recommendations until you can undoubtedly answer these questions. And please read How to End the Autism Epidemic by J.B. Hanley, which reviews all the scientific literature you have been missing. And as a reminder, Rachel Carson was once ostracized for her controversial book, Silent Spring, demonizing DDT, and now DDT is banned. So unless someone like you cares a whole awful lot, nothing's going to get
Thank
better.
you for your comment.
It's not.
Your time has expired. Our next speaker will be Ms. Mary Jo Perry.
I'm a little shorter than most.
Good afternoon. I'm Mary Jo Perry, representing Mississippi Parents for Vaccine Rights. Mississippi leads the nation in vaccine coverage rates. We also have the highest infant mortality rate in the developed world. While the reasons that our children are sick and dying involve many factors, please consider. Janie Penton, Carrier, Mississippi, died the day after 2-month vaccines. Anna Sims, Oxford, Mississippi, died 7 hours after 2-month vaccines. Last week, tiny Aubrey Harris of Columbus, Mississippi, was found dead less than 48 hours after vaccines at just 6 weeks old. I could go on. Injuries and deaths are not rare. It's time to listen to the parents. Health officials trot out the statement that vaccines are the victim of their own success. No, that's incorrect. Vaccines are victims of a greedy drug industry, powerful medical trade organizations, and their bedfellows in government. Vaccines are victims of this committee and its associates who have made overzealous, myopic decisions that have unwittingly fueled the movement that you call anti-vaccine. Along with our children, the vaccine program is your victim. I'll explain. We don't buy that our children in the USA, with clean running water, plentiful food, electricity, and state-of-the-art medical care, must have all of this to grow up safe and healthy in 2019. Our children's checkups have become high-pressure vaccine sales appointments that are more dreadful than walking onto a used car sales lot. We're outraged at the unethical practice of families being terminated by pediatricians for refusing to follow the vaccine schedule exactly. The AstroTurf backed by the drug industry and CDC, such as Voices for Vaccines, is obvious. Media hype and engineered hysteria with repeated talking points from one news outlet to the next is tired and overplayed. An orchestrated attack on vaccine freedom has descended on legislatures that is so alarming that many who call themselves pro-vaccine are seeing clearly where this agenda is heading. Whistleblowers from the inside are stepping forward daily. I get it. Our movement is an annoyance and frustrates your efforts. But how many of you would be considered to have past conflicting interests to your seat on this committee? As this committee makes decisions on how to advise our government on vaccines, I urge you to be mindful that the aggressive vaccine campaign has betrayed the public trust and backfired. Vaccines are not a victim of success. Vaccines are your victim. As a representative of the families of the most heavily vaccinated children in the nation, I implore you to temper your vaccine enthusiasm with balance and common sense. Thank you.
Thank you. Next speaker is Ms. Megan Knopf Ford.
Hi, friends. I'm Megan. I have 2 little boys, ages 2 and 5, and I drove here from Greenville, South Carolina. I'm going to tell you why I'm here in just a minute, but before that, I want to take you back on a little journey back in time. Please close your eyes or lower your gaze to your lap. I want you to take yourself back to the day when your first child was born. I want you to remember how you felt in that moment. I want you to reflect back on what it was like to hold that precious bundle in your arms for the first time and to gaze into their perfect little face. Remember all the love that you felt in your heart. It was the best day of your life and mine too. Now, you're probably wondering why I took you on that little journey, and it's to pave the way so that you are ready to receive the information that I have for you. And I'd like for you to look at me while I share my message with you. See, my story is different than everyone else in this room. I didn't vaccinate my boys. I went with my gut, and my gut said no. My instinct said there's not enough safety data. The same instinct that you were born with, it's innate. It's in all of us. We share the same instinct to protect our children. And that's why I'm here. This might sound ridiculous to you, and you might be thinking, Megan, you don't know. You're just a mother. And I would say to you, friend, this voting on vaccines with little to no safety data, this isn't enough for this mother. As you reflect back on the happenings of today, on your drive home, and as you lay your head on your pillow tonight, I have one question for you. Are you doing enough with the information that you have? You have been given a high calling. Is this enough? Are you doing what you were created to do? I know that there is at least one of you that will answer no to that question, and it's you that I am speaking to today. We need you. You have been chosen. It's time to voice your concern because you know that the greater good should not look like survival of the fittest. Your job is to protect the public, and that means all of us, not just some of us. I want you to ask for the study and do the job that you were called to do. We need your voice. It's time to believe the mothers.
Thank you for your comments. Our final speaker will be Ms. Sally Greenberg.
Good afternoon, Dr. Romero, members of the Advisory Committee on Immunization Practices. My name is Sally Greenberg, and I'm here today on behalf of the National Consumers League. Thank you for what you do for the health and well-being of all Americans and for the opportunity to speak here today. The National Consumers League is passionately pro-vaccine for a reason. The League was founded in 1899, and our first leader, General Secretary Florence Kelley, described in her letters the devastating effects to her family in losing several siblings to diphtheria, a disease we don't see anymore. We've forgotten the ravages of these terrible diseases on families. I personally grew up with my Uncle Roger. He contracted the polio virus in 1953 before the Salk vaccine was developed. He spent the remainder of his life in a wheelchair, often gasping for breath, and slept on a rocking bed to breathe. He needed 24-hour care and eventually died of disease complications. The National Consumers League is a strong proponent of vaccines, truly medicine's most precious gift to the human race. Time to listen to the parents. Well, I'm a parent also, and I thank all of you here for the fact that my 23-year-old son, who lives in Mississippi, is a very healthy young man. He does not have to worry about HPV, chickenpox, measles, mumps, whooping cough, and all the other terrible diseases that parents lived in fear of for many, many generations. On to my next point. As you know, the CDC recommends that all adults age 65 plus be vaccinated with the pneumococcal conjugate PCV13 vaccine and the pneumococcal polysaccharide vaccine. According to the CDC, these two vaccines have been proven to protect against pneumonia, meningitis, and bacteremia. As a result of ACIP's 2014 and 2015 pneumococcal vaccine recommendations and Medicare coverage of these vaccines, over 66% of total United States population has been vaccinated against the pneumococcal disease. I include myself in that number as of 2016. While impressive, this figure falls well below the Healthy People 2020 target of 90% of non-institutionalized adults age 65 plus who are vaccinated against pneumococcal diseases. In order to continue to make strides towards achieving Healthy People 2020, the Healthy People 2020 goal, we believe Medicare coverage must be maintained, which is dependent on maintaining the current recommendations. According to the National Center for Health Statistics, influenza and pneumonia are the 8th leading cause of death in the United States. We fear that without ACIP's recommendations, the current pneumococcal vaccination recommendations, which also protect patients against comorbidities caused by pneumonia, meningitis, and bacteremia, will further burden healthcare resources. Finally, changing ACIP's recommendations for the pneumococcal vaccine now
Thank you for your comment. Your time has expired.
Okay. Thank you very much for your time. Appreciate it.
Thank you. That ends our public comment session for today. We'll take a 2-minute break, please.